Ladies and gentlemen, today we are going to discuss about myocarditis. Welcome to our med class. So, what is myocarditis? This is an inflammatory process of the myocardium that results into injury of the cardiac myocytes. So, we have two terms here, myocardium and then cardiac myocytes. So the heart wall is made up of three layers. You have the innermost layer, it's called the endocardium. Then you have the middle layer, it's a muscle layer. Then you have epicardium, and then the outermost layer called the pericardium. So in myocarditis, you have inflammation of the middle layer, and this will lead to necrosis of myocytes. You should know that the myocardium, that middle layer, consists of the cardiac myocytes, the myofibrils, that is the actin, and myosin, those are the contrail components, and then the collagen fibers. So in myocarditis, you have damage to these cardiomyocytes. So we are saying that myocarditis is the inflammation of the myocardium with the necrosis of the cardiac myocytes. Let's look at the pathophysiology. Generally, you have cardiac injury followed by an immune response. And this immune response brings about cardiac inflammation. So let's give an example of viral infections. The virus will enter in the body through the surface receptor, and then the immunity is going to be activated to bring about a response. You have innate immunity and then acquired immunity. All of this will bring about inflammation. So the inflammation can bring about direct myocardial injury, which brings about apoptosis and necrosis of the cardiac myocytes. After mounting the immunity, the viruses might be cleared from the system, and that is resolution, and you have complete recovery of the cardiac walls. But in case there is continued immune response, that will bring about an ongoing myocardial injury and necrosis. That will bring about dilated cardiomyopathy. So we have seen how the virus entered in the body, an immune system was activated to bring about the response, and this response is the one that will bring about direct myocardial injury and necrosis. So what are the causes of myocarditis? Generally, the inflammation of the heart muscle occurs as a result of exposure to either an external antigen like the virus or an internal trigger such as our immunity. So we have three major causes of myocarditis. That is viruses, bacteria, cardiac toxins. Those are toxins that affect the cardiac muscle, and then autoimmunity or hypersensitivity mediators. So we have this table that is giving some of the examples of the causes of myocarditis. Under viruses, you have Kawasaki virus, adenovirus, influenza A virus. You also have HIV and influenza B. And then the COVID-19 or SARS-CoV-2. Then you have bacteria like Lyme disease, and then Mycobacterium pneumoniae can also result to myocarditis. Then you also have protozoa like Chagas disease and toxoplasmosis gondii. You have fungi like aspergillosis, parasites like schistosoma, and then also drugs. Those are the toxins. We have the famous alcohol, that is ethanol. You also have chlorazepine, those are medication. Then cocaine and tobacco smoking can cause myocarditis. We have also autoimmune conditions like SLE, systemic sclerosis, rheumatoid arthritis, and hypersensitivity reaction to various medications like penicillin. We also have lead, carbon dioxide. All this can cause myocarditis. So when do you suspect myocarditis? In case a young patient presents with unexplained symptoms of heart failure or chest pain, but coronary artery are found to be normal. What are the clinical features? So these patients can be asymptomatic, or they can have abnormalities on echo or ECG. They can have symptoms of cardiac dysfunction, arrhythmia, or heart failure, and they can also have features of hemodynamic collapse. For example, cardiogenic shock. Most common symptoms include fatigue, uh, exertion on or feeling tiredness on exertion, arrhythmias, palpitations, and chest pain. These are the most common presentation. They can also have features similar to acute coronary syndrome like severe chest pain. They can have a prodrome of fever, chills, malaise, and constitutional symptoms like general body weakness. Patients may also present with dramatic acute heart failure with cardiogenic shock in absence of any other etiology. More features include new cardiomegaly on chest X-ray. You're doing a repeat chest X-ray and abruptly you're seeing cardiomegaly. It can occur due to the inflammation. Then also atrial or ventricular arrhythmias that are new onset, partial or complete heart block detected on ECG, new onset or worsening heart failure, acute pericarditis, which will also come as a chest pain, and then cardiogenic shock. This will be unresponsive to intravascular volume administration or resuscitation, and then when you have sudden death can occur. In the investigations that you will do, ensure you do an ECG and you will see a frank ST elevation and bundle branch block can occur. Then cardiogenic enzymes. You can measure troponin. Troponin has a biphasic pattern, and therefore within the 14 hours from cardiac injury, troponin will rise. And then on echo, there are no specific findings for myocarditis on echo. However, you may find dilated spherical ventricles with reduced systolic function, small cardiac chambers, and mild reversible ventricular hypertrophy might be seen due to the inflammatory process. A pericardial effusion usually signifies myopericarditis, meaning there is inflammation across all the layers of the cardiac muscle. Ensure that you use a cardiac magnetic resonance to distinguish between ischemia from non-ischemic cardiomyopathies and certain patterns of signal abnormalities, which will strongly suggest acute myocarditis. Myocardial biopsy is a gold standard investigation and can be done in specific cases. So the clinical scenario in which endomyocardial biopsy is most useful includes sarcoidosis, fulminant lymphocytic myocarditis with VTAC. You can also use PCR to detect some of these viruses as the cause of myocarditis. This is a histological slide that is showing interstitial lymphatic infiltration, and this is a characteristic of viral myocarditis. You see infiltration of the myocytes. We have a three-tested clinical classification for diagnosing myocarditis. These criteria in possible subclinical acute myocarditis, you have a clinical context of possible myocardial injury without cardiovascular symptoms. There are no cardiovascular symptoms, but you suspect that this person might be having myocarditis. So the following will be noted. Biomarkers of cardiogenic injury will be raised. ECG findings suggestive of cardiogenic injury. And then you have abnormal cardiac function, either on echo or on cardiac magnetic resonance. In that case, you don't have histological findings, and we have already seen the imaging. So in this case, no treatment is needed. Whereas in probable acute myocarditis, so here probably the individual has acute myocarditis, but you don't have the histological investigation. So it means you'll have biomarkers of cardiac injury, they are raised, and then you have features on imaging that are suggestive of myocardial injury. So this you will treat per clinical syndrome. And then definitive myocarditis. Definitely in this criteria, if you have these features, it means you'll have myocarditis, and you'll treat depending on the specific cause. So in this definitive myocarditis, if you have histological or immunohistological evidence of myocarditis with available histological findings. So how would we treat? Generally, the treatment of myocarditis is one, supportive, then the other one is based on identification of the cause and treating the cause. So if you treat the cause, in most times, the myocarditis will resolve. So when the patient arrives and you have diagnosed myocarditis, go ahead and stabilize the patient hemodynamically with diuretics. You are ensuring that there is reduced workload on the heart. You can also give vasodilators, and this is also is aimed at reducing the workload on the heart. If a patient is unstable, you suspect cardiogenic shock and go ahead and treat with either inotropic agents, and then you can also do balloon support that can be done. So in case these patients stabilize, you can continue to maintain them with heart remodeling therapy. You can give ANC inhibitors, and that is captopril and nalapril, or you can give angiotensin receptor blockers like losartan. You can add beta blockers with or without aldosterone antagonist. In case the patient is not stable, consider adding immune therapy. These are immune modulators plus steroids. And then in case they stabilize, you can follow up with a repeat echo, CMR. This is aimed at detecting the whether the patient has progressed to have heart failure, other causes of myocarditis, their ejection fraction, how is it generally to assess the cardiac function of this individual. However, if the patient is unstable, they can go ahead and proceed to do cardiac transplantation or mechanical support. So generally, the prognosis of myocarditis is good. Most patients with acute myocarditis recover partially or fully. And then in some cases, the process may continue subclinically and eventually become severe enough to produce symptoms. And it can also progress to produce dilated cardiomyopathy. I will discuss this in my next presentation. However, the livelihood of late complications is increased in patients who present with greatly diminished left ventricular function because there will be reduced cardiac output and there will be reduced oxygen supply to the heart, and this can cause further ischemia and necrosis. Fulminant or severe myocarditis has excellent prognosis, while giant cell myocarditis has the worst prognosis because there are severe features in this type of myocarditis and the progression is very rapid. Otherwise, thank you for listening. I hope you learned something. See you